The title of this talk is Pathology of Neurologic Infectious Diseases. These are the class objectives. You do not need to read them. We will use them to chart our talk. The talk will be conducted using conversational and question and answer formats. The first question is: the muscle motor nerve interface is not protected by tight junctions. A true, B false. I will use this representation to indicate the sites of nervous system infection vulnerability made safer by tight junctions. There are 5 such sites. Number 1. The CNS parenchyma, such as the brain parenchyma indicated here, or the spinal cord parenchyma not shown here, is irrigated and drained by a complex network of vessels. This network consists of artery, arteriole, capillaries, venule, and vein. Each of these structures rely on slightly different mechanisms to form the barrier that, in normal circumstances, prevents microbes from reaching the central nervous system. In this talk, we will not discuss the barriers between CNS parenchyma and the arteries, arterioles, venules, and veins because the elements involved in forming such barriers have not been clearly delineated and the presence of tight junction not confirmed. In this talk, we will only discuss the parenchyma capillary barrier. The capillary blood-brain barrier, that is the barrier between the capillary lumen and CNS parenchyma, is constituted by special endothelial cells with no fenestration and low pinocytic index, tight junction, basal membrane made of 4 major extracellular matrix proteins, collagen 4, laminin, nitogen, and perlecan, pericytes, and astrocytic feet. It is important to stress that the same elements constitute the parenchyma capillary barrier at the level of the spinal cord as we previously mentioned. Site number 2 is the choroid plexus. This barrier is between the choroid vessel and the CSF. This barrier is constituted by special epithelial cells with low pinocytic index and tight junctions. The tight junctions are represented in this cartoon by the interrupted brown line. Site 3 is at the level of the meninges. This barrier is between the dura and the CSF. This barrier is constituted by the modified epithelial cells forming the arachnoid barrier layer. These cells are joined by tight junctions. Site 4 is at the level of the olfactory mucosa. This barrier is formed by the bodies of the sus tentacular cells, here represented in light green, and tight junctions that bind the subtentacular cells to the olfactory neuron dendrites. Site 5 is at the level of the peripheral nerve in the skin. At this level, we actually have 2 barriers. The first barrier is formed by the epidermis. As indicated here, the current thinking is that tight junctions are also present in the epidermis. The second barrier is formed at the level of the nerves. This barrier is not at the level of the endoneurium or the epineurium, but at the level of the nerve fascicle. This barrier also has two independent systems, as we will see. This cartoon represents a nerve fascicle, not the whole nerve, but only a fascicle within a nerve. In it, you can see the perineural cells forming the perineurium. These cells have the characteristic of special epithelial cells with low pignocytic index and are bound together by tight junctions. The tight junctions are represented by magenta dots in this figure. Pericytes with tight junctions are one of the two systems found at the level of the nerve fascicle. The second barrier is formed by capillaries. Notice that the walls of the intrafascicular capillary are also formed by special endothelial cells sealed by tight junction. This is the peripheral nervous system equivalent to CNS parenchyma capillary barrier. Other structures I want to point out in this cartoon are the remark bundle, constituted by a Schwann cell engulfing multiple unmyelinated axons, and individual Schwann cells myelinating axons. The muscle motor nerve interface, the neuromuscular junction, is not protected by tight junctions. So the answer to this question is A. Next question. Claudins and occludins are constituents of tight junctions. A true, B false. In this frame, you can see represented two epithelial cells. I have now represented four junctional proteins: gap junction, desmosomes, adherens proteins, and tight junctions. Tight junctions are made of claudin, occludin, ZO1, actin, myosin, and MLCK. Tight junctions are present in special epithelial cells as represented here, but as was previously mentioned, tight junctions are also present in special endothelial cells. These special epithelial and endothelial cells, in addition to tight junctions, they have, as we previously mentioned, very low pignocytic activity. So the answer to this question is A. Next question. Tight junctions in the nervous system regulate paracellular transport. A true, B false. The function of tight junctions include maintaining cell polarity, regulating paracellular transport, and forming barrier to microbes invasion. So the answer to this question is A. Next question. Which of the following elements is not involved in the blood CSF barrier? A. Endothelial cells. B. Tight junctions. C. Epithelial cells. The elements that keep microbes from going from the blood into the CSF are at the choroidal epithelium, specifically the physical barrier of the body of the epithelial cells and the tight junctions. In this frame, I have added an illustration further detailing the normal blood CSF barrier at the level of the choroid plexus. I will now proceed to label the different elements in this drawing, including those involved with the barrier. Here I am indicating the vessel lumen, fenestrated endothelium, and a space occupied by collagen fibers, special epithelial cells, and tight junctions here, here, and here. I am now indicating to a macrophage in the lumen of the vessel. And down here you have the CSF. Now let's look at scenario A. Let's just say that a microbe is in the lumen of a vessel and it goes through the vessel's wall and knocks at the door of an epithelial cell. The membrane of the epithelial cell, having little or no pignocytic index, as we have previously mentioned, will reject the microbe. A macrophage will come to the rescue and kill the microbe. In this frame, I have indicated this defense mechanism by the arrow turning up at the site of the epithelial surface. Now let's look at B scenario. The microbe managed to go between the two epithelial cells called the paracellular space, but hits the tight junction. The microbe is then repelled and suffers the same fate as the microbe in scenario A. The third scenario, labeled C, is a bit different. In this case, the microbe has managed to survive being engulfed by the macrophage. It goes through the choroid endothelium, and then the infested macrophage finds the paracellular space and attempts to go through it, but once it hits the tight junction, is rejected and pushed back to the vessel in the choroid plexus, where other mechanisms are involved in destroying the microbe. In this diagram from 1996, we can see very clearly that at the level of the choroid plexus, the tight junctions are in the epithelium, whereas at the level of the capillary CNS parenchyma, the tight junctions are in the endothelial layer. Epithelial and endothelial cells display similar protecting mechanisms and are vulnerable to similar pathologies. So the answer to this question is A. Next question. The Trojan horse mechanism is involved in hematogenous bacterial meningitis. A true, B false. In this frame, I have reintroduced the choroid plexus CSF barrier. In a situation of epithelial cell dysfunction, or if the capacity of the epithelial cell to reject microbe is overwhelmed by massive amount of microbes, or in the presence of tight junction dysfunction, microbes will go from the choroid vessel to the CSF by different mechanisms. One of these mechanisms consists of the microbe traveling through the cell cytoplasm either due to pignocytosis or receptor-mediated entry. Another mechanism is paracellular penetration, and a third mechanism is called Trojan horse. In this frame, I have illustrated these mechanisms, and in the next few frames, we are going to go through them. Example A depicts the microbe either because of its virulence or the ability to attach to a membrane receptor protein, gaining entry in the epithelial cell and ultimately reaching the CSF. In the second situation, paracellular penetration, as illustrated by B, the microbe goes through the paracellular area, finds no tight junction or destroys it, and reaches the CSF. In the third mechanism called Trojan horse, the microbe gets inside a macrophage, but the microbe is not killed. Then the macrophage reaches the epithelial cells and manages to squeeze through the paracellular space as indicated here, thus reaching the CSF. So the answer to this question is A. Next question, meningitis is more often diagnosed in children than in adults. A true, B false. The story of meningitis has been greatly influenced by vaccination in three ways. The first way relates to its overall incidence. The incidence of meningitis, and therefore the likelihood of you seeing a patient with meningitis in the ER, has significantly dropped with the introduction of the different vaccines. As you can see in this figure, the introduction of the Haemophilus influenza vaccine in 1987, the pneumococcal vaccine in 2000, and meningococcal vaccine in 2005 reduced the incidence of meningitis. The second way vaccination has influenced the story of meningitis relates to the age of the patient presenting with meningitis. This data is from 2007, yet it is still relevant today. As you can see in this frame, I have added the legend of the average age in years of patients at the time of their meningitis diagnosis. This is reflected by the green line I have just introduced. In 1971, the average age of the time of the diagnosis of meningitis was about 1 year of age. In 1995, meningitis had become a disease of the young adult. In 2007, the average age at diagnosis was about 42 years of age. These numbers are still good today. The third way vaccination has modified the story of meningitis is by changing the likelihood of finding one or another agent producing bacterial meningitis at different ages. This chart shows the percentage of cases of meningitis in different ages. In neonates, group B strep is the most common cause of meningitis. This has not changed much through the years, but all else has. Haemophilus influenza, once the most common type of meningitis in children between 1 month and 18 years of age, is now rather infrequent, whereas Neisseria and strep pneumonia are now more frequent. Between 19 and 59 years of age and above 60 years of age, strep pneumonia is now the most frequent cause of meningitis. Neisseria is more frequent between 2 and 18 years of age and at any age in patients with recent travels to areas where Neisseria meningitis is endemic, as illustrated here, or in those presenting with petechia. So the answer to this question is B. Next question. Bacteria in the CSF eats sugar and defecates protein. A true, B false. Normal CSF is characterized by clear color, an opening pressure of 5 to 20, white blood cells less than 5, all lymphocytes, protein of 15 to 45, sugar in the CSF more than 60% of the simultaneously obtained sugar in blood, and negative cultures. In most cases of bacterial meningitis, we could say in all cases of pyogenic bacterial meningitis or meningoencephalitis, when the lumbar puncture is performed late in the course of the illness or after unsuccessful treatment, the fluid is cloudy or turbid, as you can see here. Opening pressure is elevated, protein is more than 1000, but at times, especially early on, it may be much less. Most cells are neutrophils. As you can see in the CSF smear of a patient with Neisseria meningitis. This is a red cell. Here you can see a neutrophil, and inside this one you can see gram-negative diplococci. Protein is high, sugar low, and cultures are positive unless the patient has been treated with the appropriate antibiotic prior to the spinal tap. Pyogenic meningitis is characterized by exudate around the brain, as you can see in this specimen, and a bit better in this enlargement of the same specimen. For example, here. Microscopically, this translates, as you can see in this specimen, by thick meningeal infiltration by neutrophils. So the answer to this question is A. Next question. Dermal sinuses never occurred in a hairy scalp area. A true, B false. Recurrent bacterial meningitis can occur in patients with immunodeficiency, primary or acquired, and in patients with congenital anatomical defects that exposes the meninges to the skin, gastrointestinal, urinary, or otic respiratory surfaces. We will first talk about immunodeficiencies. In this frame, you can see a list of the most common immunodeficiencies leading to recurrent meningitis. HIV is by far the most frequent. All others conditions listed here are rather infrequent. But splenia is the one that most often shows up because splenia is associated with a very characteristic blood finding. This is the typical smear of a patient with splenia, showing Howell-Jolly bodies. Here and here, Howell-Jolly bodies are leftover nuclear remnants that are normally removed when blood cells go through the spleen. Having talked about immunodeficiencies, I will spend a few minutes talking about congenital anatomical defects. They are more frequent in children. The congenital abnormalities most often associated with recurrent meningitis are meningocele and meningoencephalocele that expose the meninges to the skin surface, skull base defects, such as cribriform plate abnormalities, as you can see in this frame indicated by the arrow. The organism most often causing recurring meningitis linked to this abnormality is Streptococcus pneumonia. Sphenoid bone abnormalities have also been reported as a cause of recurrent meningitis. Petrous bone abnormalities often involves the inner ear. The Mondini type of inner ear bony abnormality is probably the most frequent skull base defect linked to recurrent meningitis. You can see in this study a missing section of the petrous bone involving the inner ear. I have now added a normal petrous bone so you can appreciate the difference. Recurrent meningitis in patients with petrous bone abnormality are often due to Streptococcus pneumoniae or Haemophilus influenza. Another source of recurrent meningitis is a neuroenteric fistula. This condition is often associated with sacral agenesis, as you can see in this MRI. In these patients, recurrent meningitis is often produced by bacteria frequently found in the enteric flora, such as Escherichia coli. Another source of recurrent meningitis is dermal sinuses. Dermal sinuses are found from the tip of the nose, as you can see here, to the lumbar and coxilla regions. The head should not be forgotten. Notice that the head was shaved in order to see the communication. The bacteria most often causing recurrent meningitis in this setting is Staphylococcus aureus. So the answer to this question is B. Next question. Subdural empyema and epidural abscesses most often result from adjacent focus of infection such as sinusitis or osteomyelitis. A true, B false. Intracranial or intraspinal pus or fungal collections can be parenchymal, often referred to as axial, when they are located in the brain parenchyma or spinal medullary area. In this frame, you can see a brain abscess. Brain abscesses most often occur due to hematogenous spread and arise at the cortical gray-white matter interface, as you can see in this specimen. Brain abscesses are caused by bacterial or fungal agents. Bacterial brain abscesses are more frequent than fungal abscesses, except in immunocompromised patients. Microscopically, bacterial abscesses have two phases. An early phase characterized by an area of infiltration and associated edema, as you can see in this specimen. Notice the nidus of the process consisting of liquefied necrosis. And a second late phase that, as you can see here, is characterized by capsular formation. The capsule is easily recognized by strands of fibers running parallel to each other. Compare this side with the non-capsular side. Intracranial or intramedullary extraaxial space-occupying lesions can take the form of epidural abscess or empyema. Epidural abscesses or empyema refer to collection of pus between the bone and the dura, as illustrated here. Intracranial or intraspinal extraaxial space-occupying lesions can take the form of subdural abscesses or empyema. Subdural abscesses or empyema refer to collection of pus between the dura and the arachnoid layer, as you can see in this illustration. Intracranial extraaxial space-occupying lesions, such as subdural empyema and epidural empyema, usually occur as a complication of infection of neighboring structures, such as following frontal sinusitis. Notice the forehead swelling in this patient. Tapping with your finger in this area is very painful for the patient, because as illustrated here, the frontal sinus is usually full of pus. Intracranial extraaxial space-occupying lesion often occur after a mastoiditis following otitis media. The agent producing intracranial extraaxial empyema can usually be traced to the agent producing the primary infection. Streptococcal species are the most often causative agents in this condition. The most dreaded complications of intracranial extraaxial space-occupying lesions are herniations, mainly uncal herniation and sulfalcine herniation. What about similar lesions in the spine? Interspinal extraaxial lesions are less common but equally or more dangerous than intracranial extraaxial space-occupying lesions in the brain, because of the smaller volume of the spinal compartment compared to the cranial compartment. Most such lesions in the spine are epidural abscesses. The agent most often producing a spinal epidural abscess is Staphylococcus aureus. Warning signs of a spinal epidural empyema are fever and local tenderness over the spine, same as for the cranial lesion, but usually this is followed by 4 clinical stages: back pain, followed by radicular pain, followed by weakness, followed by paralysis. So the answer to this question is A. Next question. Zika virus vector is a tick. A true, B false. Viral meningitis or meningoencephalitis can occur the first time a patient is infected by a virus. This type of encephalitis is referred to as primary or exogenous viral encephalitis or meningoencephalitis. Primary viral meningoencephalitis is often caused by enterovirus. Enterovirus are called so because the word enteric implies intestine-related, but enterovirus should have been called human feces virus because these viruses infest the individual when food is contaminated by human feces in dirty water, contaminated soil, feces carrying flies, and feces carrying fingers. The two most common types of enteroviruses producing meningoencephalitis are echovirus and Coxsackie virus. Primary viral meningoencephalitis can also occur due to arbovirus. Notice that the first two letters in the word arbovirus are AR. Such letters link this term to arthropod and the BO to born. Therefore, these viruses are called arbovirus because of those two similarities. The mosquito is the vector for West Nile virus, Zika, La Crosse encephalitis, and St. Louis encephalitis. Ticks are the vectors for tick-borne encephalitis virus. Primary viral meningoencephalitis can also be vectored by bigger animals, rabies being an example. Rabies is transmitted by raccoons bite, foxes bite, skunk bites, and even inhalation of dropping from various species of bats. In addition to primary viral meningoencephalitis, viral meningoencephalitis can be due to reactivation. Reactivation occurs when a virus that has remained latent in the host for months or years infests the meninges and CNS parenchyma. In such cases, we talk about reactivation or endogenous viral meningitis. Viruses frequently causing this type of meningitis are those belonging to the herpes virus family, which includes herpes simplex type 1 and 2. Remember, herpetic encephalitis should be treated with acyclovir. Varicella zoster virus, Epstein-Barr virus, and to lesser degree CMV and HIV. Viruses that produce reactivation meningitis can also produce meningoencephalitis the first time they infest the host. So the answer to this question is B. Next question. Virus can reach the CNS and is covering via neuromuscular junction. A true, B false. Viruses can reach the CNS and is covering membrane by hematogenous spread, as it occurs with arterial seeding. Arterial seeding is the most common route for viruses to reach the CNS. Viruses may also reach the CNS via axonal route. Axonal transport often occurs using one of three possible routes. The first one is the olfactory neurons. Such is the case for herpes simplex, a fact that explains the preferential localization of this virus to the mesial temporal lobe, the site of the primary olfactory cortex. In this frame, I am bringing in an apparently totally different topic because the brain-eating amoeba, the Naegleria fowleri, also enters the brain via the olfactory nerves. The amoeba infests most often children while swimming in amoeba-contaminated fresh water. The letter to help recall important points about this entity is the letter F. The name of the organism is Naegleria fowleri. The organism lives in fresh water. It is often fatal, gets to the brain through the cribriform plate, and it is treatable with amphotericin. So we have talked about olfactory mucosa. A second axonal route is by involvement of the sensory peripheral nerves, with bodies in the spinal dorsal ganglia or cranial nerve sensory ganglia. This route is used by herpes simplex type 1 and 2 and by varicella zoster virus. The third axonal route uses the motor nerves. This later route of spread is used by rabies, which is, as we know, usually acquired from wild animals, but can also be acquired from unvaccinated dogs and cats. Rabies reaches the peripheral nervous system by initially attaching to acetylcholine receptors at the neuromuscular junction, somehow reaching the presynaptic region of the neuromuscular junction, and then migrating along the axon to the CNS. So the answer to this question is A. Next question. Most viruses in the CSF do not eat sugar but defecate protein. A. True. B. False. Most viral meningitis or meningoencephalitis course with clear fluid, normal or slightly increased opening pressure. White blood cells are elevated but usually not to the degree that we find in bacterial meningitis. Neutrophils may predominate early, but soon lymphocyte predominate. Protein is high, but usually not as high as in bacterial meningitis. Sugar is usually normal, except occasionally being low in patients with mumps meningitis. Cultures are positive for viruses. It is worth noticing that in most institutions, viral cultures are not done routinely. Viral PCR testing is by far more commonly ordered when viral meningitis is suspected. So the answer to this question is A. Next question. The usual incubation period of rabies is 3 to 5 days. A. True. B. False. The signs of rabies CNS involvement are often very florid, as you can see in this illustration. Stop the video and look them over. But a less florid presentation called paralytic form of rabies occurs in 20% of cases. This form is characterized by ascending weakness starting from the site of the bite, followed by spinal and brain involvement, ultimately progressing to coma and death. In general, once the paralysis starts, mortality is very high. This newspaper clipping attests to the consequence of underestimating a cat bite and of delaying the diagnosis of rabies, as it was in this case. Remember, the onset of rabies clinical manifestations, for the most part, are directly related to the distance between the site of the bite and the CNS. Hence, the incubation period for rabies is typically 2 to 3 months, but may vary from 1 week to 1 year depending on the site of the bite and other unknown factors. Going to the microscope, CNS rabies is characterized by 3 findings. The first one I will mention is perivascular coughing. Perivascular coughing is due mainly to accumulation of lymphocyte and monocyte around vessels. As you can see here, perivascular coughing results in a very obvious finding characterized by an increased number of cells wrapping the lumen of a vessel. Notice the difference around an affected vessel here and compare it with the number of cells around this normal vessel. Perivascular coughing is a non-specific finding that occurs with many viral meningitis. The second microscopic finding I like to mention to you is Babe's nodules. Babe's nodule consists of cluster of glia cells. By definition, the term Babe nodules is only used for clustering of glia cells due to rabies, but clusters of glia cells is also a non-specific finding. The third finding I want to call your attention to is Negri bodies. Negri bodies, by definition, are related to rabies. Negri bodies consist of intracellular clusters of viral particles. In this new frame, you can see two H&E stain cells with Negri bodies. Here you can see one large Negri body in a Purkinje cell, and in this other Purkinje cell you can see multiple Negri bodies. In this frame, the arrow indicates to the anon horns. In the enlargement, you can see a few pyramidal neurons, and in them you can see multiple Negri bodies. In this new frame, you can see in figure A, indicated by the arrow, a Negri body. Figure B corresponds to an electron microphotograph of a Negri body. As previously mentioned, Negri bodies are constituted by rabies virions which, if cut longitudinally, have a bullet shape, but when cut in a cross section, they look circular. I will now mention just one more thing about Negri bodies. In this frame, you see a Purkinje cell with a Negri body stained with H&E, which I have enlarged to show the relative homogeneity of the body. In this frame, you can see an enlarged Negri body, just instead of being stained with H&E, it was stained with cellular stain. Negri bodies by definition are seen only in rabies, yet intracytoplasmatic eosinophilic inclusion using H&E occurs in other viral infections. A more specific stain to diagnose rabies is cellular stain. Cellular stain permits differentiation of rabies intracytoplasmatic eosinophilic inclusions, that is Negri bodies, from intracytoplasmatic eosinophilic inclusion produced by other viruses, without the need for electron microscopy. In cellular stain, Negri bodies, as you can see in this enlargement, appear magenta and have a small dark blue interior basophilic granules, as you can see here and here. So the answer to this question is B. In the next few frames, I will match histological specimens with corresponding virus. This specimen corresponds to rabies, Negri bodies. This specimen corresponds to poliovirus. You can see anterior horn inflammatory changes in all three specimens. These elements correspond to Zika, lack of perivascular coughing, microcalcification with no inflammatory changes, meaning virus was not recognized as a foreign element because it was there too early in development. This specimen corresponds to CMV, cytoplasmatic and intranuclear inclusion and periventricular calcification. This specimen corresponds to HIV, multinucleated cells. This specimen corresponds to HIV, multinucleated cells. This specimen corresponds to JC virus, disappearance of cellular elements. This specimen corresponds to herpes simplex virus, multinucleated cells from a vesicle sank smear. Next question. This gram stain is likely to be associated with A. Cryptococcus neoformans, B. Mycobacterium tuberculosis, C. Toxoplasma gondii, D. D. Teniasolium. This question deals with 4 infective agents. The first organism mentioned is Cryptococcus neoformans. Cryptococcus neoformans is a fungal that can produce meningoencephalitis. In cases of fungal meningitis, the CSF is likely to be clear, although a thin fibrin web may be present. Opening pressure is elevated. White blood cells are usually less than 1,000, and in patients with HIV, even lower. Lymphocytes predominate. Protein is high in most fungal meningitis, but may be low in cryptococcal meningitis, according to some authors. Glucose is usually low, and culture may be positive. At times, routine gram stains may be positive. In such rare occasions, the gram stain shows large gram-positive coccus with little coccus or cocci close to them, corresponding to the budding of yeast, as illustrated here. Cryptococcus neoformans can be recognized using India ink stain in CSF. This stain stains the coccus and the CSF, but not the capsule. Hence, the capsule looks as a bright halo around the coccus, reflecting the light from the microscope. In addition to meningitis, Cryptococcus can produce cryptococcomas, as you can see in this frame. Cryptococcomas may be large enough to produce significant mass effect and mainline shift. Cryptococcus neoformans can also produce gelatinous pseudocysts, which consist of dilated perivascular spaces. These pseudocysts usually occurred in the central gray matter, as you can see in this MRI and in this fresh specimen. The presence of multiple cysts produces an appearance that has been compared to Swiss cheese. In this new frame, I have introduced an stained coronal brain specimen. Notice the many cysts in the mesoganglionic region. The new specimen I have added in this frame consists of an enlargement of a single cyst. The cysts are nothing more than a collection of Cryptococcus neoformans. Finally, at times, Cryptococcus neoformans can produce a combination of the above listed pathologies. The second organism mentioned in this question produces tuberculous meningitis. The organism is Mycobacterium tuberculosis. Tuberculous meningitis has a propensity to involve the base of the brain, as you can see here. CSF analysis is very important in patients with suspected TB meningitis. As shown here, most LP kits include 4 tubes. 3 are sent for routine testing. 1 is frozen. Keeping frozen uncontaminated CSF for future testing is important because as causes of meningitis are ruled out, new possibilities arise that may require uncontaminated and viable elements. As you can see in this table, I have written TB for tuberculosis and place an asterisk by its side. I have put this asterisk to remind me to tell you that very often in patients with TB meningitis, we find low chloride and sodium in the CSF. The fluid is often clear or there's some fibrin webs in it. Opening pressure is variable. White blood cells are in the same range as in fungal meningitis. Lymph predominates in TB meningitis as well as in fungus, probably reflecting the fact that spinal taps in patients with fungal and TB meningitis are usually not done early and the transient initial predominance of neutrophils is missed. But for testing purpose, remember that lymphocytes predominate in fungal and TB meningitis. Protein is very high, sugar is low as in any bacterial meningitis, and culture, if the precise medium is used, is positive. Mycobacterium tuberculosis is usually not present in gram stain, but may be found in Ziehl-Neelsen stains, as shown here. Tuberculous bacillus can also produce granulomas, as you can see in this frame, and often in these granulomas we can find Langhans cells. Langhans cells consist of fused macrophage with multiple nuclei in a peripheral position oriented around a tuberculosis antigen. The third organism we mentioned in this question was Toxoplasma gondii. Toxoplasma gondii is the most common cause of brain mass lesions in HIV-infected patients. This picture corresponds to an air-dried smear from cytocentrifuge sample of CSF and a stain with right stain. In it, you can see several Toxoplasma gondii surrounding a white cell. In this new frame, I have introduced a specimen of a coronal brain cut with multiple areas of cerebritis and abscesses of different size due to toxo. In and around the area of cerebritis and abscesses, we often find very characteristic small cysts consisting of vacuolated intracellular structures, full of Toxoplasma gondii, like the one in this frame. The fourth organism mentioned was Taenia solium. The parasite Taenia solium takes its name from the shape of its body. It resembles a narrow ribbon used by ancient Greek women to fix their hair. This element is called taenia. The head of the tapeworm, bearing suckers and hooks for attachment, is called scolex. The CSF of patients with Taenia solium may show an increase in white blood cells, typically consisting of eosinophiles. Otherwise, the CSF may be normal or have similar abnormalities as those found with fungal or TB meningitis. In this new frame, you can see multiple cysts consistent with neurocytosarcosis. In this frame, you can see cross-section of cytocerci or larva cyst. I am now indicating to the scolex. This is another cyst near the cerebral cortex. The location of the cyst and the mass effects explains why seizures are the most common presentation of neurocytosarcosis. I have now introduced a histological specimen corresponding to a cyst to indicate the body of the taenia and scolex, as well as the cyst capsule. The fate of most of these cysts is to calcify. This new figure shows a calcified cyst. Notice the lack of tissue reaction around the cyst. This propensity to calcify without surrounding inflammation produces a very characteristic CT appearance that is classic for neurocytosarcosis. Neurocytosarcosis is the most common cause of seizures in developing countries. So the answer to this question is A. Next question. Routine CSF labs are normal in patients with CJD. A true, B false. In 1920 and 1921, Creutzfeldt and Jacobs described a condition that now we call CJD. To understand CJD, we have to know a few basic facts about proteins. Cellular proteins need to be folded in a very specific way for them to do a good job. To achieve proper folding, the proteins require other proteins. These proteins are called chaperone proteins. On the other hand, badly folded proteins fail to do their jobs. Badly folded proteins occur for two reasons. One, bad chaperone proteins, and 2. hard to fold proteins or too much unfolded proteins. Regardless of the reason, badly folded proteins produce diseases. So all proteins need to be properly folded, as we just said, but there is one called PRPC that is particularly vulnerable to misfolding. And once misfolded, it is called PRPSC and produces CJD. At this point, you should be asking, what is it with the acronyms? This is how PRPC looks like. The term PRPC stands for prion protein cellular, a normal protein with many beneficial functions. Prion, a term derived from the combination of the letter PR, the first two letters of protein, and ION, the last three letters of infection. This normal protein is acted upon by endogenous or exogenous factors and is forced to replicate into an abnormally folded protein. This abnormally folded protein, as we previously mentioned, is called PRPSC. The reason for the letters SC relates to veterinary medicine. This protein was first isolated in sheep with scrapie. This sheep disease is called scrapie because sheep infected with this protein go to trees, trunk, and wooden poles in the field and scratch themselves to the point of losing all the wool. Notice the difference between a normal sheep and one with a scrapie. I have brought back this figure first to talk about endogenous factors leading to PRPSC. In humans, endogenous factors can trigger the conversion of PRPC into PRPSC. Some of the factors leading to these conversions are unknown. Patients with CJD, no known risk factors, and no explanation for the disease are usually referred to as spontaneous or sporadic CJD. When there is a family history of a similar condition, the term uses familial CJD. When instead of an endogenous factor, exogenous factors are at play, the terms used are iatrogenic CJD if the infestation is due to inoculation from infected human tissue, such as during corneal transplant, and variant CJD if the disease is contracted by eating infected beef. We refer to the process of infestation by using the term initiation. Following initiation, the next step in the disease process is propagation. During propagation, the attachment of an abnormally folded protein to a normally folded protein leads to the misfolding of the normal protein and the production of two badly folded proteins. The next phase is aggregation. During aggregation, the abnormally folded protein agglutinate. The consequence of these aggregates is cellular function disruption. This disruption in the brain produces three main consequences. 1. Neuronal disappearance, especially inhibitory neurons in the thalamic reticular nucleus disappear. The disappearance of these neurons lead to abnormal input to the cortical neurons, thus producing an abnormal EEG pattern characterized by triphasic complexes. In this frame, I have enlarged a single triphasic wave so you can see its configuration better. This type of EEG pattern is often associated with noise or spontaneous myoclonus. The second consequence is astrocytic proliferation. Astrocytic proliferation produces very characteristic histological findings. associated proliferation takes the form of reactive astrocytes. This is an H&E staining of brain tissue showing reactive astrocytes, also referred to as genistocytes. By the side, I have introduced a GFAP staining, also showing reactive astrocytes. Notice the large cytoplasm in the H&E specimen with peripherally displaced nucleus, the long branching processes as you can see here, and the increased number of cytoplasmatic filaments as you can see here. I would like to take a minute to show you the histological difference between reactive and normal astrocytes. In this frame, I have placed a specimen of reactive astrocyte by the side of a specimen of normal astrocytes, both using H&E. As you can see, reactive astrocytes are plump, normal astrocytes are thinner. In this frame, I have introduced two specimens, one with reactive astrocyte and one with normal astrocyte, using GFAP stain. Reactive astrocytes have longer and more filaments than normal astrocytes. The last consequence of aggregation is the appearance of neuronal microscopic vacuoles. These microscopic vacuoles also produce very characteristic histological patterns, as you can see in this cerebral cortical specimen of a patient with CJD. There are many vacuoles. Their intracellular nature can be clearly seen in some cells, like here and here. The appearance of this specimen resembles a sponge, and because of this condition occurs in association with dementia of relatively fast progression, the term subacute spongiform encephalopathy is often used to describe this condition. Spinal tap are often done in patients with CJD and sent for analysis. Regular tests are normal, but 14.3.3 protein is elevated. An elevation of this protein is found in most patients with CJD, but it lacks specificity. It can be elevated in many other conditions. As you can see in this frame, I have reintroduced the meningitis table one more time to add the CSF finding in patients with prion disease, which are normal for all the standard testing except for the elevation of 14.3.3 protein. Other prion diseases are Kuru, a now extinct disease of New Guinea's natives, GSS, an autosomal dominant slowly progressive ataxia and dementia, and autosomal dominant familial fatal insomnia. So the answer to this question is A. Next question. Eosinophilic meningeal infiltration is a frequent finding in patients with neurosyphilis. A true, B false. The pathology of neurosyphilis depends on the stage of the disease. In patients with early neurosyphilis, we find diffuse infiltration of the meninges by monocytes, lymphocytes, and macrophage. Later on, we can find similar pathology, but in addition, we find vascular involvement. As you can see in this specimen, the walls of the vessels are infiltrated by similar cells as the meninges. In patients with general paresis, a form of late neurosyphilis, we find initially microglia activation followed by frontal temporal atrophy. In patients with tabes dorsalis, we find mainly posterior column axonal degeneration due to dorsal root ganglia neuronal death. I have brought back the CSF meninges table to add neurosyphilis. In neurosyphilis, we find lymphocytes 10 to 100, increased protein, normal glucose, and positive VDRL. PCR testing available for most microbes has not so far been useful for neurosyphilis. So the answer to this question is B. Next question. The most common autoimmune encephalitis is anti-NMDA receptor encephalitis. A true, B false. So far we have spoken about exogenous factors for most organisms and putative genetic factors in the case of prion disease as causes of encephalitis. In these last few minutes, we will talk about misguided autoimmunity attacking the brain. These conditions are usually referred to as autoimmune encephalitis based on their pathogenesis or limbic encephalitis based on their predilection for involving the limbic system, especially the mesial temporal lobe. I like to stress to you these conditions for two reasons. They are curable conditions. They may be herald a neoplasm that, if early detected, can also be curable. Autoimmune encephalitis syndromes are classified according to the site of antigen-antibody interaction into extracellular and intracellular. In the extracellular group, we have NMDA and AMPA receptor encephalitis. In the intracellular group, we have anti-HU, anti-Ta, and anti-Ma encephalitis. In this talk, I will emphasize anti-NMDA receptor encephalitis because it appears to be the most frequent. This is a cartoonish representation of an NMDA receptor channel. NMDA receptor channels are made of 4 obligatory subunits, 2N1 here represented and 2N2 not represented. The magenta elements represent sites of neurotransmitter interaction. A calcium ion is being represented because of its importance in the development of symptoms in this condition, but these channels are also permeable to sodium. In normal circumstances, neurotransmitter glutamate interacts with the N1 subunit, and calcium and sodium, only calcium being represented here as we previously mentioned, enters the cell. The influx of calcium triggers normal calcium-related functions and produces receptor-dependent synaptic currents. In autoimmune encephalitis, IgG attachment to neurotransmitter site interaction leads to large amount of calcium entry and excitotoxicity. Ig attachment to neurotransmitter site interaction also produces inflammation, leading to NMDA receptor destruction and failure of calcium-mediated vital functions. I have brought back the table about encephalitis to call your attention to autoimmune encephalitis in relation to other encephalitis. This condition is characterized by clear fluid, opening pressure is variable, 10 to 1000 white blood cells. The predominant cells are lymphocytes. Protein is high. Sugar is normal. Cultures for virals and bacteria are negative. But what is important is that the IgG against NR1 subunit of NMDA receptors are present. When should you think of autoimmune encephalopathy? In every patient with encephalitis, especially if they present with psychosis reflecting the fact that the limbic system is frequently involved. In patients with mesial temporal involvement, and in patients with EEG with a very characteristic pattern, which is characterized by a slow wave with superimposed very fast activity called extreme delta brush. Now, I would like to address this question. Anti-NMDA receptor antibodies can be triggered by ovarian teratomas and rarely other tumors, and viral meningitis, particularly herpes. Hence, because of the first possibility, full body screening for tumors is of paramount importance. This is an example of an ovarian teratoma in a patient with autoimmune encephalitis. If the first study is negative, it should be repeated every 6 months for 4 years in patients with autoimmune encephalitis. Treatment of anti-NMDA receptor encephalitis consists of expeditious use of immunomodulatory and immunosuppressive therapies, such as steroids, IVIG, and plasmapheresis. One last comment before ending this long talk. The clinical presentation, radiological and EEG findings, diagnostic follow-up, and treatment described for anti-NMDA receptor encephalitis apply with minor differences to other types of autoimmune encephalitis. One difference is that other autoimmune encephalitis, especially those due to intracellular interaction, are more frequently associated with neoplasm. So the answer to this question is true. Thank you very much for your attention.